Welcome to the iWorld Live studio. I'm so happy that you're here, that you're joining us, that you're participating. This is an exciting first day for us, and we're just so excited about this. I'm here with Brandon Baartman. Brandon, we're talking about an interesting subject. They're not, there are people talk about things being controversial and all of that. This really is, okay? So
Yes.
we're talking about the use of diffractive multifocal lenses in the context of glaucoma. So let's talk about what the concern is first before we get to your study. I'm very eager to hear what you found.
Yeah, thanks, Josh, and thanks for having me on. You're right, controversial to say the least. I think that the concern with diffractive optic lenses and glaucoma is compounding an already reduced contrast sensitivity, right? So traditional dogma has always kind of told us that, we shouldn't be putting advanced optic lenses into patients with glaucoma, and sometimes that extends into those with toric lenses too, right? So glaucoma patients with astigmatism, should we put in a toric lens, or do they not deserve to have their astigmatism fixed? And so one of the things that intrigues me is that, we are talking about and thinking about and treating glaucoma differently now than we ever have before. And I'm sure that you've had a number of people come on and chat with you. And by the way, do you know how many presentations are on MIGS during this conference?
I do not.
I don't either. But I bet it's a lot, right? So honestly, I think that that it's evolving in the way we treat glaucoma patients. And one of the things that I wanted to find out was, is there a substantiated reason why we shouldn't be offering patients as much spectacle freedom if they have something like mild to moderate glaucoma? And so that's what we were most interested in answering with our study.
That's great. Now, so I want to reiterate in my own sort of nerdy, geeky way some of the things that you've said. First of all, I agree with you, I think, in distinguishing completely toric lenses from multifocal
Correct.
lenses. And the
Yeah.
reason is that what we're interested in modulation transfer function, don't be scared by that term, uh, uh, in that context, is we want the highest spike possible because the idea has been, the dogmas you say, there's this reduction that takes place in glaucoma patients of that MTF spike.
Correct.
And toric lenses in an astigmatic eye will give you a higher, not a lower spike. Now, the opposite is true
Correct.
with multifocal lenses. There is a price for multifocal lenses, and I don't mean a financial cost. I mean that there's an optical cost for it, and that cost is the reduction of the highest peak of the modulation transfer function. You pay for multifocality with, as you said, decreased contrast sensitivity. Tell me about this study. What was the study, and what were your main outcome measures?
Right. So we wanted to design a study that was different from the other studies that are out there. I'm sure you are aware that there are some studies that have looked in a cross-sectional way, pseudophakic patients, those with monofocal lenses, those with diffractive type lenses, and said, okay, who performs better with visual field testing parameter metrics, right? So mean deviation, visual field index. But those were cross-sectional studies and looking at patients who had already had surgery. And by the way, these were on healthy eyes. So what I wanted to know is, what about those patients with glaucoma that were perhaps getting an intervention for glaucoma at the same time as cataract surgery, i.e. an eye stent, and determining a pre to post visual field change? Is it different if they get a monofocal versus diffractive lens? So we did a retrospective study, 80 eyes from 51 patients. 40 of them got a monofocal lens, and 40 of them had a diffractive type optic. Now, much like some of the other studies in the literature, we included a variety of different diffractive type optics from different companies. And what we found was, when we looked at visual acuity, outcomes, best corrected visual acuity, as well as visual field parameters, there really was not an appreciable difference between the delta of pre to post visual field testing in monofocal lenses versus the diffractive optic types. So what that told me, in conclusion, at least what I took from it, is in the immediate term, when we're looking purely at those patients impacted by the cataract surgery alone, before to after the cataract surgery, there wasn't a significant difference in visual field. That visual field latency averaged about a year. So again, this is a short-term difference, right? But in those patients with mild to moderate glaucoma, cup-to-dish ratios, average in both groups was about 0.6. It wasn't a significant differentiator between the diffractive optic and the monofocal.
Brendan, this very, very, very interesting and an encouraging finding. Let me set things up like this, though. So, I love doing MIGS. I think the innovation of MIGS has really changed the way that I practice. It is my hope that all of my mild to moderate glaucoma patients who receive MIGS stay mild to moderate, but of course, that is not uniformly the case. However, I'm implanting a lens that the patient's going to have for the rest of his life.
Correct.
What happens when these patients are no longer mild to moderate?
So that's the tough question to answer. And so the question that I would put back to you is say, if we are concerned, how much do we know about these patients individually, whether or not they're going to progress or not? Now, we've got new metrics, right? We've got corneal hysteresis, which might predict progression of glaucoma as well. And so maybe that's a metric we pay more attention to when we're talking about lens options for these patients. And I'm not necessarily advocating that we go out and put multifocal lenses in all mild to moderate glaucoma patients, but one thing that I wanted to know was, is it reasonable? Is this something, if a patient comes to you and says, Josh, that I have mild to moderate glaucoma, don't really have a lot of visual field loss, it really doesn't bother me, I don't know I have it, but I have a cataract. We know that both glaucoma and the cataract can reduce quality of life in these patients. Would you be willing to consider an advanced optic like a diffractive lens in a patient with open-angle glaucoma if you don't know 10, 20 years down the road for them?
Right. So that's a wonderful question, and I do have patients. I do have patients who come to me in Manhattan with a level of sophistication that they can ask and understand the answer to a question like that. However, even in my practice, they're not the majority of patients. How the hell do you explain to a patient what the issues are in a way that they can make an informed choice?
Right, and that's the challenge, and the onus is on us to be able to explain, the same way we explained, just as you did eloquently earlier in the discussion, these lenses work by cheating the optical system, right? They split light. And so by nature, you're going to have a reduced amount of light for your distance vision and reduced for your near vision. It won't be 100% at any distance that you look, right? And so that same conversation can lead into those patients with mild glaucoma where you say, look, I don't know what your visual field is going to look like years down the road, but because we are doing two things now, we're going to take out your cataract, which we hope is going to lower your pressure, and we're also going to do a glaucoma intervention at the same time. My hope is that we can at least slow the progression to the point where you don't outlive your glaucoma outlives you, right? So ideally these patients end up succumbing to something before they realize the negative effect of their glaucoma, and my hope would be that the compounding effect of the lens, that at least the benefit that gives them, the diffractive lens optic type gives them up into the point where they no longer have functional vision, is more beneficial to them than having, had a monofocal lens for the rest of their life.
Yeah, this is wonderful, wonderful stuff, and you're to be applauded for doing this, because it is essential that where there isn't evidence that it is fine to accept dogma, but evidence always trumps dogma, and I'm delighted that you've done this.
Yeah, you know what? I think that, like I said before, I don't know that I'm an advocate for this, but I'm certainly not an advocate for the opposite, which is to say, to the patient sitting in front of me, you are excluded because 20 years down the road you may have a problem because of the glaucoma plus this lens.
You're saying that there is a context that exists in which this is not an unreasonable choice. And
Correct.
Even that is, as you said at the very start, a controversial thing to say. But if you've got the facts, you use the facts.
Right.
Brendan, I want to thank you very much. This was a fascinating conversation, as off camera you promised me that it would be, and you're a man of your word. I want to thank you very much for bringing this really very complicated topic to us, for making it so clear, for getting me to reconsider some of the things that I'm thinking, and I'm sure for getting you to reconsider some of the things that you've thought too. This was a wonderful use of my time at Brandon's expense. I know it was a wonderful use of your time too. Thank you for joining us on this iWorld Live event.
Thanks, Josh.